Okay, good afternoon, everybody. I think we're going to get started. Thank you so much for coming today. My name is Gib Clark. I'm a program associate at the Environmental Change and Security Program and the Global Health Initiative here at the Woodrow Wilson Center. Today we are proud to be launching the 2005-2006 National Family Health Survey from India. We're going to start here with a short video before we get to our speakers. But first, let me just say a little bit about the Global Health Initiative, which is putting this program on today, and about the Woodrow Wilson Center. The Wilson Center was founded in 1968 as the living memorial to President Wilson, with the goal of bringing together the worlds of ideas and policy. The Global Health Initiative was started about a year and a half ago here at the center in response to the fact that of the 20 programs and projects at the Wilson Center, almost all of them were addressing health in one way or another. So the Global Health Initiative functions as a clearinghouse for all the center's health programming. But it also has 4 major health topics that we look at: health's impact on development issues, the role of international and national institutions in global health policy, infectious diseases, and emerging health technologies. As I said, we're co-sponsoring this event with the ECSP, the Environmental Change and Security Program here at the Wilson Center. We're excited to be putting this event on. This is the first NFHS, National Family Health Survey from India, in 5 years. Since it was started in the 90s, this has been the most reliable and up-to-date source of information on population health and social conditions in India. It has rich data from national and state sources. This most recent survey comes from over 200,000 interviews with men and women throughout the nation, and it presents results for a wide array of indicators, including education, HIV, child survival, contraception, domestic violence, fertility levels, and nutrition. We have 3 experts with us today for this discussion. The bios, which are available outside, have much more information, but let me quickly say that Sunita Kishor, who will be starting, is the Senior Gender Specialist at Macro International and a co-manager of technical assistance for the NFHS. She has been instrumental in developing and refining and promoting gender indicators, including indicators of gender-based violence that are widely used throughout this survey. Next will be Fred Arnold, the Vice President at Macro International. Previously, he had a difficult posting in Honolulu as Deputy Director of the East-West Population Institute and as Research Director of the Select Committee on Population for the House of Representatives. Finally, Kamla Gupta is a professor and head of Department of Migration and Urban Studies at the International Institute for Population Sciences in Mumbai. She is also the chief coordinator of this survey. Before we do get started, though, with the presentations from our speakers, we're going to watch about a 20-minute film.
When the government and other organizations need information on health and family welfare in India, one of the key sources they turn to is the National Family Health Survey, or NFHS. 3 rounds of the NFHS surveys have produced accurate, reliable, high-quality data on population, health and nutrition at the state and national levels. The first NFHS took place in 1992-93 and the second in 1998-99. NFHS 3, which was conducted in 2005-2006, gives us an opportunity to assess current levels of the health and family welfare situation in India, to examine how far the country has come since NFHS 1 and NFHS 2, and to compare the current situation with the goals set out in plans and programs. Like the earlier surveys, NFHS 3 was conducted under the stewardship of the Ministry of Health and Family Welfare. The International Institute for Population Sciences, or IIPS in Mumbai, is the nodal agency for conducting NFHS. 18 research organizations carried out the NFHS 3 fieldwork. Technical assistance for the survey was provided by Macro International, NACO and NARI. Funding assistance for NFHS 3 was provided by several funding agencies. USAID was identified as the donor coordinator for NFHS 3. Field workers for NFHS 3 traveled to every state, including remote areas, to ensure that the survey was nationally representative. They interviewed almost 125,000 women and 75,000 men. Both married and unmarried women and men were included in the survey. Compared with the two previous surveys, NFHS 3 collected a broader range of information. Field workers used questionnaires translated into 18 languages to collect information on a wide range of topics, including fertility, maternal and child health, and HIV/AIDS. Specially trained health investigators measured height and weight and conducted blood tests for anemia in adults and young children. After getting permission from the respondents, health investigators also collected blood samples from adults for anonymous HIV testing. This has enabled NFHS 3 to provide the first community-based estimate of HIV prevalence in India. All blood collection and testing was done in accordance with Indian and international ethical and blood safety guidelines. NFHS surveys provide the Government of India, state governments, NGOs, international agencies and researchers with credible data to assess the health, family welfare and nutrition of the population and to track progress. The survey results are very useful in planning and formulating policies for health and family welfare programs for the benefit of all sections, including the vulnerable and weaker populations. For the first time in Indian history, more than half of married women, that is 56%, are using a family planning method.
ಚೊಕ್ಕ ಕುಟುಂಬ ಎಂದಾಗೆ ಈಗಿನ ಆಧುನಿಕ ವಿಜ್ಞಾನದಲ್ಲಿ ನಮ್ಮ ಮಕ್ಕಳಿಗೆ ಬೇಕಾದಂಥ ವಿದ್ಯಾಭ್ಯಾಸ ಅವ್ರಿಗೆ ಬೇಕಾದಂಥ ಅವಶ್ಯಕತೆಗಳನ್ನ ಒದಗಿಸೋದಕ್ಕೆ ಅನುಕೂಲ ಆಗುತ್ತೆ. ನಾವು ವ್ಯವಸಾಯದಲ್ಲಿ ಹೆಚ್ಚಿಗೆ ಸಂಪಾದನೆ ಇಲ್ಲ ನಮಗೆ, ಅದರಿಂದ ಮಕ್ಕಳು ಜಾಸ್ತಿ ಆದರೆ ಅವ್ರಿಗೆ ಸರಿಯಾಗಿ ವಿದ್ಯಾಭ್ಯಾಸ ಮಕ್ಕಳಿಗೆ ಬೇಕಾದಂಥ ಅವಶ್ಯಕತೆಗಳನ್ನ ಪೂರೈಸಲಿಕ್ಕಾಗಲ್ಲ. ಅದರಿಂದ ಚಿಕ್ಕ ಕುಟುಂಬ ಬೇಕು ಅಂತ ನನ್ನ ಅನಿಸಿಕೆ.
Most women who have 2 children don't want any more, even if both of their children are girls. Overall, 4 out of 5 women with 2 children said that was enough.
এখন মানুষ এখন উন্নত হয়ে গেছে অনেক, তা চাইছে যে আমার একটাই বাচ্চা নেব যাতে বাচ্চাকে ভালোভাবে মানুষের মতো মানুষ করতে পারি, তাই জন্য মানুষ এখন একটাই নিচ্ছে। আর এখন আর্থিক দিক থেকে আবার অনেকের আছে, আর্থিক ক্ষমতাও কম, যার ফলে অত নিয়ে কি করবে, তাকে তো মানুষ করতে পারবো না, বেশি বাচ্চা নিয়ে কি করবো, তাকে ঠিক মতো খাওয়াতে হবে, পড়াতে হবে, লেখাপড়া শেখাতে হবে, তাই জন্য মানুষ একটা দুটোই নেয়।
Some couples in India still want sons rather than daughters, but son preference is steadily becoming weaker. In NFHS 1, only 37% of women with 2 daughters and no sons said they did not want any more children. That percentage grew to almost half in NFHS 2 and to 61% in NFHS 3. Because of the desire for smaller families, the total fertility rate in India today is 2.7 children. That means women, on average, are having only 2 or 3 children. Urban women have an average of 2 children, as compared with rural women who have 3 children on an average. Lower fertility rates are sweeping across India, but they have not yet blanketed the entire country. 10 states, mostly in the south, are already at or below replacement level fertility. That is, the level at which each couple has only about 2 children to replace themselves. Another 7 states are close to achieving replacement level fertility. In 9 states, the total fertility rate is between 2.5 and 3.6 children. However, women in 4 states, Bihar, Uttar Pradesh, Meghalaya and Nagaland, still have larger families with almost 4 children on average. Women's decisions about when to have children are also important. Ideally, women should space births 3 to 5 years apart in order to reduce neonatal, infant and maternal mortality, and to make sure that children are well nourished. In India, however, the majority of women use family planning to limit rather than space births. This helps explain why 60% of birth intervals, that is, the number of years between births, are shorter than recommended. According to NFHS 3, only 18% of women who use family planning are using one of the 3 modern spacing methods: the pill, IUD, or condom provided under the national program. Among contraceptive users, the share of modern spacing methods increased from 14% in NFHS 2 to 18% in NFHS 3. But 2 out of every 3 contraceptive users are still using female sterilization. In 10 states, more than 1/4 of contraceptive users use modern spacing methods, ranging from 27% in Uttar Pradesh to 49% in Delhi. NFHS 3 has also documented gains in maternal health care. More women than ever before are receiving care from health professionals during pregnancy and delivery.
हम लोगों ने एक नई पॉलिसी शुरू की है जिसमें गांव की जो महिलाएं होती हैं उन्हीं में से कुछ महिलाएं अपॉइंट कर दी जाती हैं एज आशाएं, जो कि प्रेग्नेंट लेडीज़ को पूरे 9 महीने तक वो हम लोगों के पास लेके आती हैं चेकअप कराने के लिए और उन्हें प्रोत्साहित करती हैं कि वो डिलीवरी हॉस्पिटल में कराएं और 1 महीने तक डिलीवरी के बाद भी बच्चे का इम्यूनाइजेशन और माँ का ख्याल रखना उन्हीं की जिम्मेदारी होती है। तो इस हिसाब से तो आजकल बहुत डिलीवरीज आ रही हैं यहाँ पे। लोग चाहते हैं, मतलब लोग यही कोशिश करते हैं कि अपनी हॉस्पिटल डिलीवरी कराएं।
डिलीवरी इवाग ಮೊದಲಿಗೆ ನಾವೇ ಮಾಡ್ತಾ ಇದ್ದೋ ಜಾಸ್ತಿ, ಇವಾಗ ಹಾಸ್ಪಿಟಲಲ್ಲೇ ಹೆರಿಗೆ ಆಗಬೇಕು ಅಂತ ಹಾಸ್ಪಿಟಲ್ಗೆ ರೆಫರ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಅವರೇ ಸಮಯ ಅಂದರೆ ಹಾಸ್ಪಿಟ್ಲಿಗೆ ಹೋಗಿ ಡೆಲಿವರಿ ಮಾಡಿಸ್ಕೊತಾರೆ. ನಮ್ಮನ್ನು ಕರೆದಾಗ ಅಕಸ್ಮಾತ್ ಅಲ್ಲಿ ಬೇಗ ಕಾರೋಗಿರೋ ಆಟೋಗೀಟದಲ್ಲಿ ವ್ಯವಸ್ಥೆ ಮಾಡಿ ಹಾಸ್ಪಿಟ್ಲಿಗೆ ಬೇಗ ರೆಫರ್ ಮಾಡ್ತೀವಿ. ಈ ಥರ ಎಲ್ಲ ಅನುಕೂಲ ಮಾಡ್ತೀವಿ.
Women are increasingly likely to receive care during pregnancy and to deliver at a health facility. In NFHS 1 and 2, about 2/3 of women received some care during pregnancy. Today, more than 3/4 of women do so. Progress has been even greater for deliveries. In NFHS 1, only 1 out of every 4 women delivered their babies in a health facility. That increased to 1 out of every 3 women in NFHS 2. Today, 2 out of every 5 women deliver their babies in a health facility. Despite these gains, much remains to be done. Over half of all Indian women are still delivering their children at home, and almost 1/4 do not receive any antenatal care during their pregnancies. Over 90% of urban women receive some antenatal care, compared with less than 3/4 of rural women. Similarly, more than 2/3 of urban women deliver in health facilities, compared with less than 1/3 of rural women. Indian women have already reaped health benefits from their decisions to adopt family planning and have fewer children. The next steps in improving maternal health are to encourage women to space births more widely and to seek care from health professionals during pregnancy and delivery. India has one of the fastest growing economies in the world. Despite the economic boom, progress on child health and nutrition has been painfully slow. Results from NFHS 3 and other surveys recently prompted Prime Minister Manmohan Singh to call for urgent action at the state level to improve children's nutritional status and increase immunization rates. Immunization is one of the most effective preventive health measures available, but childhood immunization rates in India remain low. Less than half of children aged 12 to 23 months receive all of the basic immunizations, including BCG that protects against tuberculosis, measles, and 3 doses each of polio and DPT for protection against diphtheria, tetanus, and pertussis. the proportion of children who were fully immunized rose only slightly, from 42% to 44% between NFHS 2 and NFHS 3. However, almost every child receives some vaccinations, which means that the health system is reaching them at least once, but not consistently.
जैसे अपना स्वयं जाकर के अपना नियमित बच्चे को टीकाकरण कराते हैं, पोलियो ड्रॉप पिलाते हैं, हम लोग हालांकि मार्गदर्शन करते हैं, उत्साहित करते हैं, लेकिन ज़्यादा उत्साहित करने की आवश्यकता पड़ती नहीं है। स्वतः ही वो समझते हैं, जानते हैं, अपना नियमित टीकाकरण कराते हैं। प्रतिदिन समस्या कोई समस्या तो जाकर के एनएम से मिलते हैं या एनएम खुद आके सेवाएं उनको प्रदान करती है। साथ ही आशा बहू है, वो अपना समय समय पे जिसको कोई प्रजनन संबंधी या टीकाकरण संबंधी कोई समस्याएं हैं तो उसको देखती रहती है, अपना समझती रहती है, उसका निदान करवाते रहते हैं।
Progress has been uneven for different vaccines. For example, the Pulse Polio campaign has made great strides in immunizing children against that disabling disease. Since 1992, the proportion of children receiving all 3 doses of polio vaccine has risen from about half to over 3/4. In contrast, there has been almost no change in how many children receive DPT vaccine. Immunization is less common in rural areas. NFHS 3 found that 2 in 5 young children were fully immunized in rural areas of India, compared with about 3 in 5 children in urban areas.
अगर पैसा लेकर किया होगा तब तो कोई पिलाने का सवाल नहीं। देहात में, शहर में तो पिला देंगे। शहर में जहाँ पे जो एजुकेटेड फैमिली है वो तो पैसा लगेगा, तब भी दूर जाना पड़ेगा तो भी वो पिलाएंगे। लेकिन देहातों में जो अभी एजुकेशन की तो कमी है, ये अनएजुकेटेड पॉपुलेशन है, तो वो उनके यहाँ मुफ्त में भी पिलाने दर दर जाते हैं तो भी जल्दी से पिलाने। कहीं बूथ बैठ जाते हैं कि यहाँ आके पिलाइए तो नहीं है, घर हम चले जाएं भले जाकर उनको टीका लगा दें, लेकिन बूथ पे वो आकर के टीका लगवाने के लिए जैसे इंडिफरेंस है, तो कोई मतलब नहीं है।
National data on childhood immunization in India mask large differences between states. In only 5 states have 70% of children or more received all recommended vaccinations. In another 10 states, half of children or more are fully vaccinated. State-wise changes in vaccination coverage over time reveal surprising results. In 5 states, childhood immunization rates have climbed by 20 percentage points or more since NFHS 2. Recent trends in 7 other states, including Maharashtra and Mizoram, are much less promising. After increasing in the 1990s, childhood immunization rates have actually fallen substantially since NFHS 2 in these states. Urgent action is needed to turn the situation around and put India on the road to universal childhood immunization. Widespread and persistent malnutrition undermines the normal growth and development of children throughout India. 20% of children under age 5 in India are wasted. That is, they are acutely undernourished or too thin for their height. This is one of the highest rates of wasting in the world. Unfortunately, there has been little improvement in nutritional markers in recent years. The proportion of children under age 3 who are underweight has decreased only slightly, from 43% in NFHS 2 to 40% in NFHS 3. The prevalence of anemia among children aged 6 to 35 months has actually grown a little worse, rising from 74% in NFHS 2 to 79% in NFHS 3. If we look at all children under 5 years of age, NFHS 3 finds that malnutrition is especially widespread in rural areas where nearly half of children are underweight and close to 3/4 are anemic. However, even in urban areas, 1/3 of children are underweight and almost 2/3 are anemic. Among the poorest families, over half of young children are underweight. However, NFHS 3 reveals that nutritional problems in India are not simply an issue of poverty. Many children in prosperous families also suffer from malnutrition. The same pattern is seen for anemia. About 3/4 of children in the poorest families are anemic, but so are half the children in the wealthiest families. Nutritional problems in India also affect adults. More than half of married women in India are anemic, and the prevalence of anemia actually increased from 52% in NFHS 2 to 56% in NFHS 3. Undernutrition is widespread, but overnutrition is emerging as the new challenge for adults. about 1/3 of women and men are too thin, but 13% of women and 9% of men are overweight or obese. The prevalence of overweight or obese adults is particularly high in urban areas, among the better educated and in wealthier households. Thus, Indians suffer from a dual burden of malnutrition, with close to half being either too thin or too fat. NFHS 3 is the first survey in India to test a nationally representative household-based sample of adults for HIV. Blood samples were collected from more than 100,000 men and women nationwide. The survey found that the prevalence of HIV in India is low at 0.28%. That means that 1 in every 350 adults aged 15 to 49 years is infected with HIV. In 2007, the National AIDS Control Organization revised the official HIV estimate for India based on household data from NFHS 3, data from the Sentinel surveillance system, and other information. Based on all this information, NAGO estimates that 0.36% of India's population, or 2.47 million persons, are living with HIV, less than half the previous estimate. The survey found wide differences among the 6 states for which state-level estimates were calculated. From Uttar Pradesh, where HIV is rare, to Manipur and Andhra Pradesh, where HIV prevalence is about 1%. This suggests the potential for a more widespread epidemic unless steps are taken to educate people about HIV and about how to prevent. With 2
That was, I hope, gave you some sense of what our results have been. And the 3 presentations you're going to be seeing today, I'm going to start with a short presentation on the domestic violence part of the survey. And this is just so that we can be different. Usually domestic violence data comes at the very tail end as an afterthought. So we thought we'd be different, and I'm going to start with it. And then we're going to talk about nutrition, and then finally HIV, as Gib said. As you can see, it's just a very small part of what there is in the NFHS, but clearly we just wanted to introduce you to everything there is, but not try and cover it. But we can take questions on any aspect of the survey later on. All right. So we've got, in the NFHS, we tried to document domestic violence in India. the question often arises, why measure domestic violence in a national health survey? Perhaps not in this audience, but very often when we are out there and we are talking to audiences in India, this question perpetually comes up. The clear reason, and perhaps the foremost reason, is that domestic violence is a violation of human rights. It's a violation of the human rights of women. Another reason is India is a signatory to CEDAW and ICPD and Beijing agreements, and therefore they have to monitor what's happening on this front. It has significant economic costs, which are often ignored, and these costs are in terms of health. It includes loss of women's labor hours and increased healthcare costs. And finally, it has significant documented public health consequences, including effects on unwanted fertility and contraceptive use, rates of HIV and other STIs, infant and child mortality, and of course immunization and other health care for children. So, having persuaded the government and everybody else that domestic violence has a place in NFHS 3, it was incumbent on us to measure it in a way that we would get valid results. So the approach that we took to violence measurement in NFHS 3 is very similar to what we are doing in other countries for the demographic and health surveys. And what we do is we try and measure different forms of violence, including physical and sexual violence for all women. This is what we did in India. So this would be all women, married and unmarried. We also emphasize focus a large amount of our data collection on spousal, physical, sexual, and emotional violence, because a very significant proportion of our sample is a sample of ever married women. And we do have data on violence initiated by women against their husband. In order to collect these data, we followed Indian and international guidelines for the ethical collection of data on violence. And the methodology that we used is known to produce more valid results and has two key features. It provides multiple opportunities for disclosure and asks about specific acts of violence so that there is no misunderstanding of what we are trying to ask about. So we don't use summary terms like violence or beating, because what you may interpret as violence may not be what the respondent interprets as violence or sees as violence. I will today, in the interest of time, focus on our results on spousal, physical, and sexual violence mainly. How did we define these different forms of violence? Physical violence was measured using several, as I said, we asked about several different acts. And if a woman said that any of these acts, whether it's pushing her, whether she was pushed, shaken, or her husband threw something at her, if she was slapped, if her arm was twisted and her hair was pulled, if she was punched, kicked, dragged, beaten, etc., and more serious types of violence, he tried to choke her or burn her on purpose, threatened her or attacked her with a weapon. All of these are forms of violence, and they were treated as forms of physical violence. We also tried to get at spousal sexual violence. If she was forced to have sexual intercourse against her will when she did not want to, or she was forced to perform other sexual acts against her will. Emotional violence, we tried to measure through whether he tried to do or say something that was to humiliate her in front of others, threatened to harm her, or someone close to her, or insulted her, or made her feel bad about herself. Now, these are the overall results we get. The green bar is violence ever by the spouse, and the blue bar is violence in the past 12 months. And the results show that 2 out of every 5 women report some form of spousal violence, and 27% report having experienced such violence in the past 12 months. If we restrict it, if we leave out the emotional violence and stick with physical or sexual violence, which are far more valid measures, and consistently across the world these measures have been proven to be valid, we see that the rate is 37% of ever experiencing violence. Most of that violence is in the form of physical violence. However, 10% of women, ever married women, report sexual violence by their spouse, and 16% report emotional violence. Only 1% of married women have ever initiated violence against their husbands. So yes, there is violence by women against their husbands, but at least as reported by women, undoubtedly it may be an underestimate, but it remains low. The other question that we try and answer is also of great relevance, and that is, when exactly does the typical violence first begin? When is it initiated in a marriage? Very often we come across people saying, oh, well, you know, she gets old, she gets lazy, so her husband beats her up. No. As you can see, this is not a live table. This is just currently using the results we have. What you have here is, if at the intersection of the X and Y axis, that's when the marriage begins, you see that within 1 year of marriage, 7% have reported having experienced violence. And within 5 years of marriage, 32% have reported experiencing violence. And this effectively, given that 37% of women in our sample report having ever experienced violence, this implies that 87% of spousal violence is initiated within 5 years of the start of the marriage. Some of it actually occurs a little before, depending on how long the couple actually have known each other. So most of the violence, in other words, the message here is, this is not something that happens later on. If violence occurs, it tends to begin early in the marriage. And again, this is a result we do find in countries other than India too. So then the next question becomes, who are these women who are subject to violence? Are there characteristics that we find that are common? Again, this is not a multivariate analysis. The data is just now, it has just become available. But using bivariate analysis, we ask the question, how does prevalence of spousal violence vary by individual characteristics? And the three questions I'll briefly answer here are, what characteristics of women and their husbands are relevant? And then something which is extremely important, because this is probably the only policy instrument that we really have in terms of characteristics of women, and that is, what is the relationship of spousal violence with education? And then finally, are there other factors other than education which affect prevalence of violence? Very briefly and very clearly, spousal violence increases with the age of women, because it's a longer period of exposure, and the number of children, which is highly correlated with age. It decreases with wealth, as expected, and is higher for employed women than unemployed women. Those are some of the general background characteristics that we look at. When it comes to education, here too we find very clearly that spousal violence is much more common among women who have no education than among women who have 12 or more years of education. So the contrast is 46% versus 12%. If we look at the husband's education, we get fairly similar results. However, it is particularly notable. The blue bar is the husband's education. So roughly, if the husband has no education or the wife has no education, you have about 46-47% of women reporting violence. But if the husband has 12 or more years of education, 21% of women whose husbands have 12 or more years of education report violence, compared to only 12% of women who have 12 or more years of education. Suggesting, I mean, open to further analysis, suggesting that a woman's own education has a greater impact on her ability to control or to prevent or to, whatever the factors are that contribute to violence occurring, than if her husband has education. Nonetheless, whether it's the husband who's educated or the wife who's educated, you do get much lower rates if there is education than if there is none. The other question is, whose education makes more of a difference? The other question that we've dealt with, the other question is spousal education difference. The question of whether it matters, whether there is a huge differential in education. As you can see, if neither are educated, about half the women, where neither member of the couple is educated, report violence. However, if you look at the other end, if both are equally educated, that is, both are educated and they're equally educated, you get the lowest rate of violence. So it's not just, it's clearly a reinforcing factor if both are educated. You might notice that there is, if it's in between, that the husband has more education or the wife has more education, you get about 1/3 of the women reporting violence. And the third question we were going to ask about background characteristics is, what other factors are strongly associated with the likelihood of spousal violence? And the two most important factors, and that the ones with the strongest correlation or effect, are husband's alcohol consumption and whether the respondent's father beat her mother. And if you look at the results for husband's alcohol consumption, you see that among women whose husbands get drunk very often, 69% report ever having experienced physical or sexual violence. And if the husband never drinks, it's 30%. Now, these results are extremely revealing because it does suggest that those who blame alcohol consumption alone for domestic violence or for spousal violence are in fact only partially correct. Because even if the husband does not drink, 1/3 of the women report having experienced violence. That is not a trivial amount. Yes, if he drinks, it goes up tremendously. And this next characteristic is something which is not in the woman's own control, and yet it points to the importance of the intergenerational effect of violence. So even if we do not care what happens to women today, we should at least care about what happens to the children tomorrow. And you can see that you have pretty much the same thing going on. That if the woman's father beat her mother, she is twice as likely to have ever experienced violence herself from her spouse than if her father did not beat her mother. Now, violence has consequences. And as you can see, I'm not going to go down the list because it's pretty horrendous, but almost 38% of women who have experienced violence report having experienced some form of injury. Most of you will not be able to see the names of states or even recognize them. However, I did want to point out that the picture is not necessarily uniform across India. You have a large number of states where the rates of violence are pretty, relatively speaking, low, where it ranges from 6% in Himachal Pradesh to 59% in Bihar. Unfortunately, most of the most populous states in India, namely UP, Madhya Pradesh, Rajasthan, and Bihar, are all at the upper end of this. They have over 40% of women reporting violence in these 4 states. Finally, the question, another policy, another aspect of violence which can be affected by policy is from whom is the question of whether women who experience violence are able to get help. So we tried to find out from whom do women who are abused seek help. What we found was that only 1 in 4 abused women have ever sought help. And women are much less likely to seek help for sexual violence than for physical violence. So most of the women who said they had tried to seek help had experienced physical violence. Hardly anybody who had experienced sexual violence said they had tried to seek help. When women seek help, they do so mainly from family members, not from institutions. Despite the fact that several police stations, in fact, almost all police stations are supposed to have a women's cell to help women. But 2% of women who had experienced violence of any kind said that they had gone to the police. Other organizations, too, as you can see, is 1% religious leaders and social services, etc. The other notable thing is, in fact, help seeking varies very, very little, if at all, with any of the background characteristics you would have thought would make a difference. So in summary, almost 2 out of every 5 ever married women in India are subject to some form of spousal violence. Women rarely initiate violence against their husband, and most spousal violence begins within 5 years of the start of the marriage. And finally, most women suffer violence in silence. And I leave this as a parting thought. If we knew that more than 1/3 of women had a debilitating disease that is wearing them down mentally and physically, would we continue to ignore it? Thank you.
Okay, thank you very much. Before I turn the floor over to Fred, I forgot to mention 2 things. One, I'm kicking myself for, which is that we have a reception which follows this event just right across the hall here. And secondly, I'd also like to thank the Asia program for co-sponsoring today's event. Fred?
Thanks, Gib. Good afternoon, everyone. Sorry again about the video. Before all of you arrived, it ran through from beginning to end without a single glitch. So, I'm going to talk a little bit more about nutrition in India, both children's nutrition and adult nutrition. You already saw some of the rather stark results before in the video, before it broke down. And I want to start out with, first of all, originally we had planned to have this topic first, so I do want to once again thank a lot of the organizations that were very instrumental in this survey. There were more than 30 organizations involved overall, but the major ones were the Ministry of Health and Family Welfare, Government of India, the International Institute for Population Sciences, and here you have the 5 major funding groups with USAID as the donor coordinator. I want to start out with a quote from Amartya Sen. India's record in countering hunger and famine is strangely mixed. The rapid elimination of famine since independence is an achievement of great importance. And yet, India's overall record in eliminating hunger and undernutrition is quite terrible. Not only is there persistent recurrence of severe hunger in particular regions, but there is also a dreadful prevalence of endemic hunger across much of India. Indeed, India does worse in this respect than even sub-Saharan Africa. Now, these results have caused quite a stir in India and abroad. You already saw from the video that Prime Minister Manmohan Singh has referred to these results in a letter that he wrote to the chief ministers of each of the 29 states, telling them that the nutrition programs have not been successful, and saying that we need to revamp the nutrition programs, and asking the chief ministers to report back to him every 3 months on what they've done and how effective it's been. So it's been noticed at the highest levels of government. Also, there have been lots and lots of newspaper articles, TV shows, the basic tenor of which is the Indian economy is booming, but the children are getting left behind, at least in terms of nutrition. Now, these are the facts. If we look at the 3 normal measures of undernutrition in children, this is under age 5, we find that almost half of children in India are stunted. That is, they're too short for their age. Almost as many are underweight. They weigh too little for their age. And 20% are wasted. That is, they're too thin for their height. And wasting is an indication of acute malnutrition. Acute malnutrition, and stunting is chronic malnutrition. Now, when we first came out with results quite similar to this 15 years ago in NFHS 1 and then again in NFHS 2, some people said, well, you really can't use the international reference population for comparison because Indians are just naturally shorter and smaller than people elsewhere in the world. And the question is this true? And the answer is no. Indian children do grow at the same rate as children anywhere else in the world when they are allowed to reach their full genetic potential. And this was shown in a seminal study 15 years ago by the Nutrition Foundation of India, and also just last year by WHO. When we look at differentials in the underweight, which is one of the measures, we see there are some substantial differentials, but there's almost no difference between the nutritional status of girls and boys. We found that also in NFHS 1, we found it in NFHS 2, we see it in the anemia results, we see it in the child feeding results. There are no differences. Now, sun preference is still strong in many parts of India. There may be discrimination in other areas, such as medical care for children, employment, or education, but nutrition is not an area where there is any differential at all. Basically, when parents have girls, they take just as good care of them as they do boys in terms of nutrition. Inadequate nutrition is higher in rural areas, as you might expect, among scheduled caste and scheduled tribe children, children with short birth intervals, those are riskier births, and higher order births. And underweight decreases sharply with the mother's education and the household wealth. Here you can see just one example how underweight prevalence varies by wealth. It's about 3 times as high in the lowest wealth quintile as in the highest wealth quintile. But I should mention that even in the highest wealth quintile, 20% of the children are underweight, and in a normal population, you would expect only 2 or 3% of children that age to be underweight. So it's still very high, even in this more advantaged group. If we look at trends in child nutrition, we have to look at children under age 3 because NFHS 2 only weighed and measured children in that age group. And we see here there's been some improvement in terms of stunting from 51% to 45%, but it's still quite slow. It's about 1 percentage point a year, and clearly at that rate it's going to take several decades before a large majority of children are properly nourished. Underweight has changed very little over the period, and wasting has actually increased. And this is because the children are growing taller faster than they put on weight, so this increases their wasting. And that's bad for children at that age. Some people have looked at this almost in a positive way, even though it's a very high rate, because it means that these children are less likely to be overweight or obese when they reach adulthood. Now, anemia is very widespread in India. It's characterized by a low level of hemoglobin in the blood. As you saw, we took the blood for testing the hemoglobin levels. Anemia in children often leads to impaired cognitive and motor development, and it's usually, not always, caused by nutritional deficiencies, especially iron deficiency anemia, vitamin A, B12, folate, etc., but it can also be caused by infections such as malaria or hookworm infestations. Anemia is very widespread. You see here there are 8 states in India where more than 70% of young children are anemic, and there are only 4 states in the entire country, most of them small states, that have an anemia prevalence of less than 50%. And overall, India's anemia prevalence for children is almost twice as high as the WHO estimate of anemia in children in all developing countries put together. Now, one of the things about anemia is that it's extremely high in all groups, even the most advantaged groups. You see in urban areas, 2/3 of children are anemic. Among the wealthiest households, the wealthiest 1/5 of households, more than half are anemic. If the mothers have 12 or more years of education, again, more than half of the kids are anemic. And once again, girls and boys there are no differences here. And anemia has not gotten better over time. In fact, the situation has worsened a bit over time, and even severe anemia has gone up slightly. So despite massive efforts in India to deal with child nutrition, they're not really having the desired effect. Now, turning briefly to adult nutrition, the poor nutrition conditions of young children have received much attention recently, but adults are also experiencing a variety of nutritional problems. You can see that more than 1/3 of women and more than 1/3 of men are too thin, are abnormally thin, and very high rates of moderate to severe thinness, 20% in women and 14% in men, and then a growing problem with overweight or obesity. 13% of women and 9% of men throughout the country are either overweight or obese. And even in obesity and overweight are mostly problems in the urban areas, in the most educated segments of society, and in the wealthier households. And in the highest wealth quintile, almost 1/3 of women are overweight, including 8% who are obese. And you can see here where some of the places where overweight and obesity is becoming a tremendous problem. In the major metropolitan cities, Delhi and Mumbai, more than 1/4 of women are overweight or obese. Calcutta, almost 1/3, and the highest of all is Chennai, 39%. And among the states, Punjab has the highest rate of overweight or obesity, 30%. Now, one of the things we measured for the first time in NFHS 3, we oversampled both slum and non-slum areas in 8 major cities. So for the first time, we have been able to look at how different the slums are from the non-slum populations. And of course, we do find a lot of differences in the key indicators. But even in the slums in Chennai and Hyderabad, 1/3 of women are overweight or obese. And in all of the 8 cities we looked at least 20% of women living in slums are overweight or obese. So this isn't kind of the usual picture you think of when you think of slum dwellers, but obviously any nutrition programs for adults do have to deal with both ends of the spectrum. And here I put together the 2 different nutritional problems as stacked bars. So you can see in the blue area at the bottom the percentage of women who are underweight, and the purple bars at the top the percent who are overweight, broken down by residence and education. And as you can see here, if you just look at the top of the bars, it's amazingly consistent, amazingly constant. Almost half of women are either underweight or overweight in any of the groups. And you can see even though the urban-rural in urban-rural areas there's no difference in the total, In urban areas, about half of those who have a nutrition problem are underweight and half overweight, whereas in rural areas, underweight is about 6 times as high as overweight. You see the same kind of thing by education, by wealth quintile, and you also see the same thing if you look at NFHS 2 and NFHS 3. The gains that have been made in underweight over the last 7 years have exactly been offset by an increase in overweight. If we look at anemia in women and men, we can see that more than half of women are anemic, and during pregnancy, 59% of women have anemia. And during pregnancy, you can particularly see very high levels of moderate to severe anemia. A third of pregnant women have moderate to severe anemia. Men also have a substantial amount of anemia, but as expected, not as high as women. If you look at where we find anemia, it's throughout the country, really, almost everywhere. But there's a sort of a band of states in the red over on the East Coast, starting down with Andhra Pradesh, Orissa, Jharkhand, Bihar, and West Bengal, and then going up into Assam and Tripura in the northeast. This is the band with the highest levels of anemia among women. So the conclusion for adults first: the adult population suffers from a dual burden of undernutrition and overweight or obesity. Almost half of women in most population subgroups are either too thin or too fat. Women's nutrition has not improved in the last 7 years, and overweight or obesity is a growing problem. Men are much less likely than women to be anemic as expected, but their nutritional status is still not satisfactory. Although the percentage of women and men who are overweight or obese is still much lower than it is in the US or any other developed countries, the potential threat of growing problems of overweight cannot continue to be ignored. For children, the conclusion is that children in India suffer from some of the highest levels of stunting, wasting, and underweight in the world, and the situation has not improved markedly in recent years. Anemia levels among children have actually increased since the time of NFHS 2 7 years ago. Now, I haven't shown the next two things, but there's a lot of information in the report. Most recommended infant and young child feeding practices are widely ignored by parents, and that's one of the main causes of nutritional problems in young children. And the main government program, the Integrated Child Development Services Program, which deals with nutrition in India, has been established for 30 years, but in that time it has not been able to reduce malnutrition to acceptable levels in any state, even the better off states. Well, I'm sorry for all the bad news. I want to end on just a slightly more optimistic note. The good news, I would say, is that there's no longer any doubt that nutritional problems in India need to be urgently addressed. This has really captured the imagination of many higher-level government officials and others in India. Many officials now seem energized to take on the challenge and to develop innovative programs to get results. In response to the Prime Minister's letter, many of the states have already started innovative programs to try to have better nutrition programs, one of which is having public-private partnerships to run the government nutrition programs through the ICDS centers. The chances of success remain to be seen. We all hope that NFHS 4 and other data collection efforts in the coming years will be able to document the fruits of these efforts. Thank you.
Okay, thank you very much, Fred. And now for our final presentation, Kamla.
Good afternoon and greetings from India. At the outset, let me thank USAID and Macro for inviting me to present the findings on HIV knowledge and prevalence in India. There are several topics which have been covered in the National Family Health Survey 3 regarding knowledge, behavior, stigma, attitude, as well as on the prevalence. But I am going to present only some of the key findings related to HIV/AIDS knowledge, family life education, the way we have measured the HIV in NFHS 3, coverage of HIV testing in NFHS 3, and HIV prevalence. And now I am going to present the findings related to knowledge of AIDS by residents. As I have told you earlier that a couple of questions have been asked, and the very first question which was asked about the knowledge among men and women was whether they have heard of HIV/AIDS. And we find that 4 out of 5 men and 3 out of 5 women in India, they have at least heard of HIV/AIDS. Now, the knowledge is, as is thought, is higher in urban area than in rural area, but the gap in the knowledge of HIV/AIDS for women is higher between rural and urban areas. Now, we have also collected the information about the prevention and transmission of HIV, and using that we have tried to find out more comprehensive knowledge of the HIV/AIDS and how we are defining the HIV/AIDS comprehensive knowledge. That is related to prevention, that is those who know that using a condom and having just one uninfected partner limits the risk of getting AIDS, and that a healthy looking person can have AIDS, and those who reject the 2 most common misconceptions about AIDS transmission, that is transmission by mosquito bites and by sharing foods. So on the basis of these prevention and transmission and the misconception, we have formed this comprehensive knowledge indicator, and we see that you have seen in the earlier slide that the knowledge about AIDS is relatively high, both for, particularly for men, 80%, 84% of men, they have at least heard of AIDS. They also know, 70% of men also know that the HIV/AIDS can be prevented by using condoms. But as far as the comprehensive knowledge is concerned, only 1/3 of males they know about or they are aware of the comprehensive modes of prevention and the transmission of HIV/AIDS. And this percentage is really very, very low for women. We have also collected information from men and women about the family life education, and this is basically because of the fact that National AIDS Control Organization have initiated several programs for increasing the education and awareness about HIV/AIDS as well as behavior change. And it was important to know that what the people think, what men and women think about several aspects of family life education. So all this information was collected in NFHS 3, and we see that majority of women, they think that it is the children should be taught in the school about the pubertal changes in boys' body as well as in girls' body. There is also quite high acceptance among women for children to be taught in school about HIV/AIDS, but as far as the sex and sexual behavior is concerned, contraception is concerned, and the condom used to prevent STD is concerned, the acceptance is little less. And we find a similar picture for males also. A larger proportion of males, they agree that boys and girls should be taught about the changes at the time of puberty, both to girls as well as to boys in schools. They also accept that the HIV/AIDS topic should be taught in the school, but as far as the sexual and sex behavior and condom use and contraception is concerned, men also have little less acceptance. But nevertheless, as far as HIV/AIDS is concerned, more than 80% of males in India and more than 60% of women in India, they have favorable attitude that children should be, both girls and boys should be taught about HIV/AIDS in schools. Then I now present about, as you have seen in the video, that it is for the first time that in NFHS 3 we are providing the community-based HIV prevalence estimates. So it was very important for us to follow all the international guidelines to provide the HIV estimates, and our goals to provide the HIV estimates were like this: using international guidelines for the ethical and safe collection of blood, estimate HIV prevalence for India in the general population by sex, by age, urban-rural residents, and a group of states. Then NACO has identified 6 high prevalence states. So our goal was also that for each of the NACO's 6 high prevalence states, these are Andhra Pradesh, Karnataka, Maharashtra, Manipur, Nagaland, and Tamil Nadu. Out of these 6 states, 4 are in South India and 2 are in Northeast India by sex. And then also to provide the HIV prevalence estimates by sex for a low prevalence state, and that is Uttar Pradesh. Now these estimates were to be based on the blood collected from a representative sample of women aged 15 to 49 and men aged 15 to 54. Now this is the way we have collected blood for HIV testing in NFHS 3. Now blood spots from a finger, as you are seeing in the picture, blood spots from a finger prick were collected on a special filter paper. Now since it was an anonymous testing, so no names or personal identifiers were placed on the filter paper sample, and self-adhesive barcodes levels bearing the same numbers were affixed to the filter paper card and the questionnaire for each individual respondent. So this is the way we have collected the blood and we have linked the data. Now after collection, these samples were dried overnight in a drying box with desiccants and humidity indicator cards to take care of the humidity. Now these appropriately packaged DBS samples were transported to the SRL Ranbaxy collection centers. Ranbaxy, they have a large number of collection centers all over India, but they opened many more collection centers for collecting the blood for HIV testing for our survey. Now these collection centers, they have the responsibility to send or to transport these blood samples to the central lab in Mumbai in a biosafe manner. Now out of the total samples, 5,000 DBS samples were sent to National AIDS Research Institute, that is NARI, in Pune for external quality control. Now this included all the positive samples, these 5,000 samples included all the positive samples as well as 5% of the negative samples. Now this is the way we have linked the HIV test results to the questionnaire data. The HIV test results were linked to the questionnaire data through barcodes. You have seen that the barcodes bearing the same number were fixed on the questionnaire, on the filter paper, and that is the way the results were linked. And to preserve the anonymity further, when the data files were merged, cluster and households numbers were scrambled, and before the questionnaire data file was merged with the HIV test result file. Now, I present the coverage of HIV testing in NFHS 3. Actually, when we undertook the HIV theme in NFHS 3, there was a lot of skepticism among the people that it will be not possible for NFHS 3, which is a large-scale survey, to collect the blood for the HIV testing. And people were very skeptical that we will not be able to get the high prevalence rate. So it is important for us to give you some idea about the coverage rate for HIV test in India. Now, as you have, we were to provide the HIV prevalence rates for the adult in the women age 15 to 49 and men age 15 to 54 in the selected households. Now, we could not collect the blood in Nagaland because of the strong local opposition, and therefore, the NFHS 3 final results are, prevalence estimates are based on nearly 103,000 HIV samples, and that includes nearly 50,000 blood samples from men and 53,000 samples from women. Now, the coverage rate for women in India are 85%, and for men it is 78%, and these response rates are very much closer to the response rates that have been observed in national household surveys elsewhere in the world. So in India also we have sufficiently high coverage rate. Now the reasons for the non-coverage was for the men, the most important reason was that not interview, and the protocol, HIV testing protocol, included that the blood will not be collected for those who are not being interviewed because of any reason. So 14% of, in case of men, the blood could not be collected for 14% of men because they were not interviewed, and this is 6% for women. Nearly same percentage, 6 and 5% cases the blood could not be collected because they refused to give the blood. As I have told you earlier that we have followed all international guidelines and the ethical procedures to collect the blood, and there was, this was a voluntary blood collection. So in case of 6 and 5% of females and males, the blood could not be collected because they refused to give the blood, and the other two reasons are very small. Now these are the response rates for the 6 states, 5 high prevalence states and 1 low prevalence states, that's Uttar Pradesh. And you see that in case of Tamil Nadu and Manipur, the response rates are quite high, more than 90% for males, and except Manipur it is 82%, but females it is 91%. In Andhra Pradesh and Uttar Pradesh, the rates are very similar to the national average. Only in case of Karnataka and Maharashtra, the rates, coverage rates are, response rates are slightly lower than the national average. Now I present the results about the HIV prevalence in India, and you see that actually the video stopped there. So it is good that I am presenting those results, that the HIV prevalence rates for women and men in the age group 15 to 49 in India is 0.28. And many of you may be aware that earlier we did not have any community-based survey. Most of the prevalence rates as well as the numbers of the people infected with HIV was coming from the Sentinel surveillance from NACO. But this survey shows that the prevalence rate is 0.28%, and our confidence interval is also low. The rates may range somewhere 0.23 to 0.33, which is not very high. As expected, the prevalence rate is low for women, that's 0.22%, and it is relatively higher in case of men, 0.36%. Now this is the prevalence rates by residence and sex, and you see that the prevalence rates are higher in urban areas, both for men and women, than in rural areas. Now, these are the prevalence rates for 5 high prevalence states. At ranges, the prevalence rate is highest in Manipur, followed by Andhra Pradesh, Karnataka, and Maharashtra, where more than 0.5% of the people are infected, men and women are infected with HIV. The Tamil Nadu, which happened to be identified as the high prevalence states by NACO, the prevalence rate is only slightly higher than the national average, that is 0.34%. And for men, actually, the prevalence rate is even lower than the national average. And this is one state where the prevalence is higher among females, among women, than among males. And for Uttar Pradesh, as it was expected, the rates are very low, both for women and men, 0.10 for men and 0.05 for women. And if we take all the non-high prevalence states together, the prevalence is 0.12, 0.16 for men and 0.08 for women. Now this here we provide the female-male ratio and the rural-urban ratio, and you see that at the national level, the prevalence rate is 40% higher in urban areas than in rural areas. And when we see female-male ratio, the female ratio is 1 to 1.6, so the prevalence rate is nearly 61% higher among males than among females. And if you see the female-male ratio for different states, the highest female-male ratio is in Manipur, which is a high prevalence rate, as well as in Uttar Pradesh and the non-high prevalence states. It is the same prevalence ratio. But this ratio is same in the high prevalence states as well as in Uttar Pradesh and in the low all the non-high prevalence states together. The prevalence ratio, female-male ratio, is at the national level in Andhra Pradesh, Karnataka, and Maharashtra. And Tamil Nadu, as you know, that the prevalence is higher among women than among men. So the female-male ratio is 1 to 0.7. Now this is, we have provided, if you see the report, the prevalence rates have been provided by a number of characteristics. And here I present just the results, the HIV prevalence by age. And you see that in the lowest age group, that is in the 15 to 19, the prevalence, overall prevalence rate itself is very low, and it is low both for women and men. And this prevalence rate increases till the age of 30 to 35, which has the highest prevalence rate both for women and men, and then it declines, starts declining in the later age groups. As I told you earlier, that our male sample was taken for all the men in the age group 15 to 54. So for males, we have the prevalence rate in the age 50 to 54 also, and here the prevalence is 0.34, which is slightly lower than the national average for the men as a whole, or more or less say. Now, it is very important that people are aware of their HIV status, because that helps them to plan the strategies for taking care of the treatment, as well as other strategies that they may decide to have. Therefore, we have collected information about the previous HIV test for women and men. And if we see the prevalence among those who have been ever tested and those who are never been tested, so you see that the prevalence is relatively much higher among those who have been tested earlier for HIV. And this is particularly more prominent in case of males. The prevalence among the ever tested men is more than 4 times higher than never tested men. Now, as we have collected information from the sampled household for all men and women, therefore this data on women and men can be linked to identify the married couples in the survey. And married couples in which both the wife and the husband were tested for HIV in NFHS 3, this can be used to study the discordance in the HIV prevalence between husband and wife. And this study of discordance is very important to plan the effective strategies for the interventions. And we could identify nearly 27,771 married couples who were tested for HIV in NFHS 3. And out of these, 138 couples were like that, in which the wife or the husband or both husband and wife were HIV positive. And among these 138 couples, if you see, for 22% both the husband and the wife were HIV positive. In 64% cases, only the husband was HIV positive. We have a small number, that's 14%, where only the wife was HIV positive. So this is a very important finding to be taken care while planning the strategies for the effective interventions. Now, as I have already told you, that the prevalence of HIV in India in the age group 15 to 49 is low, that's 0.28%. And in 4 states, the prevalence is more than 0.5%. That's in Manipur, Andhra Pradesh, Karnataka, and Maharashtra. And it's much 61% higher among males than among females, and 40% higher in urban areas than in rural areas. Now, the government has taken the NFHS results very positively, and on the basis of the NFHS 3 estimates of HIV prevalence and other data, the government of India has revised its official HIV estimate from 0.92% to 0.36%. But I will not say that it is a good news, because even if the prevalence is low, we still feel that strong programs are required to prevent the further spread of HIV. Thank you very much.
Okay, thank you very much for 3 great presentations. We're going to move to the question and answer session here. When the microphone is passed to you, please let us know who you are, say your name and affiliation. There's a question back there in the corner.
John Fino, RTI International. I just have a question about the HIV prevalence. Actually, 2 questions. First, the issue of the relationship between nutrition and HIV, in particular transactional sex. Was that at all addressed in the survey, or the specter of that coming up in the future? Second question, do you have any data on male circumcision or sexually transmitted infections with the HIV data?
We have a question on circumcision in our survey, but the prevalence estimates are there for those who are circumcised and not in the report, but I have not presented over here, so the issue is addressed over there. As far as trans sex is concerned, we have not collected any specific data on that, but if such people are staying in the households, they are in our sample, but we really do not have separate estimates for them.
Yeah, just a couple of clarifications maybe. One is we did ask men about payment for sex. It's fairly low, but the HIV prevalence rates are considerably higher for those who have paid for sex. And Nutrition, we have a lot of data on nutrition and HIV as well. So, by the way, the data sets are already available freely to anyone through the Measure DHS website, and so we hope people will look into this. The question of male circumcision is a very difficult one in India because it's mostly related to different practices among different religions. And so, if a lot of whatever effect we see could in fact be due to religious differentials in sexual behavior and things of that nature. So, maybe a multivariate analysis will help understand that a little bit more. But, with all of these things, the prevalence rates are so low that it really limits the analytical capabilities, even though we have a very large sample.
Right up here.
Question on the domestic violence issue, if I may. My impression is that India still is predominantly patriarchal, and when a woman marries, she marries into her husband's family and frequently joins a household with other members of her husband's family, including the mother-in-law. So the mother-in-law plays a major role in decisions and in what goes on in the household. Did you probe that question at all? What I'm thinking of is that a few years ago there was a spate of stories about bride burning and about the problem of groom price and contracts entered into at the time of marriage, which the bride's family perhaps had difficulty fulfilling, and then they took it out on the bride by abusing her and beating her and subjecting her to violence. Is that not somewhere in this picture of what goes on in the household and the presence or absence of domestic violence?
The way we try to capture some of the mother-in-law aspects of violence is essentially by asking women, all women, whether they had experienced violence by anybody else. And in fact, you rarely get at all, and this is true not just this time, but in NFHS 2 also, if at all you get violence by just a mother-in-law, it's very rare. Violent behavior, what appears to be truer in India is that it is sort of reinforced, so you always have the husband actually being the one who is being violent. And women rarely report a violence by a mother-in-law. And we did not probe any emotional violence by a mother-in-law, which may also be extremely important in this. What we did probe was physical violence by other members of the household, and we really don't get a whole lot. Married women report violence by spouses. There's very little else. And I think what possibly happens in families is there is not that, there is a lot of this going on, but perhaps the mother-in-law sort of condones her husband's beating of his wife rather than actually being the one who's doing it. And yes, there are sensational cases which make the papers, but we don't necessarily find a huge amount of evidence of women reporting that.
Okay, let's take the two questions and then row right behind him.
Nalini Singh, Professor of Pediatrics, Head of Infectious Disease at Children's here in Washington, D.C. So your question regarding domestic violence in two parts. One is, did you survey children in the household where there was a reported domestic violence? Because domestic violence seems to perpetuate in generations. So if they see the parents' behavior, the children grow up to be abusive. And the second question is, you reported if the mother saw violence in her father beating her mother, there was a correlation. I'll be very interested to know if the husband saw this was the norm, he saw his father being abusive to the mother, and if you surveyed that. I'll take that answer. Thank you.
We're going to take just one more question. Go ahead.
Hi, I'm Samia Altaf. I'm the Pakistan scholar at the Woodrow Wilson Center. I have two very short, quick questions. One is for Fred and the other one is for Kamla Gupta. And thank you very much. This is very interesting and fascinating survey. Fred, it's a very remarkable clustering of the malnutrition around the sea on the East Coast. So I haven't read the report. So is it possible that it could have something to do with the diet in that particular area? Although you don't see that on the West Coast. So if there's that difference. The question for you, Kamla, is that I don't know, maybe it's covered in the report, but did your methodology include a protocol for treating people who were identified positive for HIV, or it didn't?
Oops. Because it is an anonymous survey, so.
But they were.
Yeah, okay. But after the blood collection, we have given a reference to all the people who were tested for the blood, to if they want to know about their HIV status, because we only collected the blood and the testing was done in the central laboratory. But we gave a brochure to all male and female who were tested for blood, to if they want to know about their HIV status, they can go to the nearby VCTC center. And that was arranged by NACO.
Your first question was with regard to violence against children per se. We did not interview children. However, we do have the age group that we are covering is 15 to 49 for women. And it is both married and unmarried. So although we do not get, we don't speak to anybody who's younger than 15 to the extent that 15 to 18 or even 15 to 18 are still children by most worldwide standards. We do get information on that group because we directly interview them. And we do get, and that's largely your never married sample of women, and that's you get about 16%. And yes, amongst those, you do get a lot of it is parental violence. And in fact, one of the pieces of data I did not present is that if you look at the very small proportion who do report sexual violence, a big factor there is relatives. So there is, but it's a very small, if I remember correctly, it's really 1 to 2% who report sexual violence in the never married group, which is largely the younger lot. Your second question was, no, I've forgotten it. It was right there.
The second question was, you reported that whether the mother side of the family, the father was being abusive. I was just curious if the husband side, who's the perpetrator?
Right. What we can find out in India, which is not often true, is that although we did not directly measure prevalence of violence, because we, in accordance with the WHO standards for the ethical collection of data on domestic violence, we do not collect information on prevalence of violence from both men and women in the same households. So we did not get prevalence of violence. However, we did include the same question we asked women about whether the parental interspousal abuse by the parents. We asked that question to men too. That analysis has yet to be conducted, but undoubtedly, using couple-level data, we can look at the likelihood of a woman getting beaten if her husband observed violence. So that potential exists.
Yeah, and in terms of the anemia, I'm not quite sure why that's true. I mean, one thing I would say, first of all, is that those states have the highest levels of anemia, but a lot of the other states have also very high levels of anemia. And, 3 or 4 of those states are coastal states, but not all of them. Jharkhand, Bihar, and Assam are landlocked. And then, as you say, down the west coast, they are not experiencing the same problem. So even though they may be eating more fish in some of those states, it's not clear why that would have an effect. So we need to look into the potential determinants of anemia in those populations.
Okay, a couple of questions in the back there.
Hi, Carl Howe, Population Reference Bureau. One thing I noticed in those early fact sheets that came out before the book was that there was an interesting jump in contraceptive prevalence in traditional methods, particularly in UP. And I just wondered if, is there any explanation for that, or is it perhaps the interviewers were instructed to probe on that particular subject more deeply? Or anyway, it did kind of stick out, and I just wondered what that was.
Okay, pass the microphone back. Thank you.
Gary Cook from USAID's Bureau for Asia and the Near East. First of all, congratulations on carrying out of a massive undertaking, a very important undertaking, successfully. Congratulations on that. My question has to do with the HIV/AIDS prevalence, which this very reputable survey found to be 0.28. And the government bought into the survey all along and everything. What led them then to modify their national prevalence estimate to 0.3 something instead of the actual figure 0.28?
Okay, and we'll take one more question right next to him, please.
Sandhya Rao with Emerging Markets Group. I was just wondering, over the course of NFHS 1, 2, and 3, what have you learned with regard to respondent bias and interview bias, and how have you taken those lessons learned, whether general or specific, into account in NFHS 3 in particular, with some very sensitive information, obviously, that you've been collecting?
Whatever word you guys like, go ahead.
Yeah, go ahead with HIV.
Yeah, actually, as expected, ours is a household survey, and there is a possibility that we might have missed some of the population, that is high-risk population, or some of the population which could not be contacted because, say for example, truck drivers. If they are in the trucks, then they are not coming in our sample. And there were other surveys also which were initiated by NACO to look into the high-risk behavior among certain specific groups. So on the base, taking care of all that, they modified the prevalence from 0.28 to 0.36%. So basically, it is expected, though we have all the population, that lives in the household, but there is a possibility that we might have missed some of the high-risk population. And since they have other surveys also initiated at the same time, so they took the HIV prevalence rate of the high-risk population from those surveys and then calibrated the results.
Yeah, we were trying not to repeat things which were in the video, but since you didn't see that part of the video, the previous official estimate of the number of persons living with HIV in India, according to the Government of India estimate, was 5.2 million, and according to the UN AIDS estimate was 5.7 million, and now the official estimate that everybody has agreed on is 2.47 million. So more than 3 million lower than the previous estimates, and we were really worried that this was going to be misinterpreted by the media, by organizations, as a huge decline and a successful program, but fortunately that generally has not been the case. That people have gotten the story that it actually was just better data and better estimation measures. We have done two kinds of analysis of the HIV prevalence results. One is a non-response analysis based on the survey, and we looked at all the characteristics of the people who gave blood for HIV and those who did not. And when we do a multivariate analysis and try to predict HIV among the non-respondents, we find out that it's no different at all from the respondents. So in other words, the ones who didn't give their blood or who weren't interviewed are really no different. And we also looked at the homeless population, or in India the houseless population they're called, based on the census results, and tried to come up with some reasonable estimates of what HIV prevalence might be in that group. And putting both of these two things together, we concluded that 0.28 is the most reasonable estimate from a household level, but that in no case was it reasonable to assume that HIV prevalence could be greater than 0.4%. And so the 0.3% that the government finally decided on was well within those limits. And Carl, we don't really know. We had planned to do some qualitative analysis of traditional method use in UP, but the funds were needed for other purposes, so we never did that. But all of the surveys in UP have found increasing rates of traditional methods, even though there aren't any really substantial programs for those methods. So you yourself may have some thoughts about what might be causing that.
Yeah, I guess that means that I answered the last question about lessons learned. Lessons learned over time from the 3 surveys. I think Fred was the one who was there from NFHS 1 onwards. I joined the team for NFHS 2 and I have been directly involved both in NFHS 2 and NFHS 3. And I think in terms of what we have tried to improve between surveys, one is training. I think it's an extremely important lesson that we sort of constantly try and improve our methods of trying to train the interviewers to do their job correctly, to do it ethically, and to understand the questions themselves so that they are able to probe correctly. And I think over time, DHS, those of us at Macro who've been involved with the DHS now for not each one of us, but whatever, we've been doing the DHSs for a long time now, and this is a general sort of important finding that if you want to get good results, it's a lot of it. It's in your questionnaire. It's on the simplicity with which you're able to ask your questions. And it is in the training, because it's not Fred or me or anybody else at IIPS who is asking the questions. It is the interviewers. And it is training with a level of commitment, increasing the understanding of interviewers to what they are doing for the country. The level of commitment becomes extremely important. And in our training, we try and promote this feeling of how important the data are. And the ethical side of the data collection is also extremely important. If I think respondents feel that they are either threatened or being forced or, any of those feelings, they are much less likely to cooperate. And from the sensitive data point of view, I think internationally speaking, we have a long way to go to try and maximize disclosure of sensitive information. But we are making steps, especially when we look at, say, the domestic violence information. Women are coming forward and they are reporting. With regard to actual sexual behavior in terms of whether they've had partners outside of marriage, I think we still have a long way to go in large-scale surveys. There are some sensitive data which really are not amenable or easily collected well with very large-scale surveys. And there is, in terms of the NFHS, Fred, how many interviews did we have throughout the country? Probably
about 2,000.
2,000 people in some form or the other were out there collecting data. So that's a lot of people to train for very sensitive information, and yet we attempted it. I think we have some way to go, but we've made a lot of strides.
Okay, I think we have time for one more question. Up here, please. Yep, right here in the middle.
My name is Nandini Kutty. I'm an independent consultant. My question is about nutrition, the data on nutrition. It is a matter of concern that there are such high levels of nutritional deficiency throughout the population, but even more worrisome is the fact that the problem has worsened. It appears to have worsened in the last 7 years or so. So my question is, are there any surveys that are tracking the eating habits of the Indian population in the last 7 years? Because my sense, I mean, this would just be a hypothesis on my part, I don't have data for it, but my sense is that in both urban and rural areas, the consumption of aerated drinks, of packed snacks, very highly processed foods with additives and artificial flavors and so on, which might inhibit the absorption of nutrients. So I was wondering if that might be a factor in the worsening of the situation.
Thank you. Yes, we do have information on broad categories of food consumption among women and men, both in NFHS 2 and NFHS 3. But mostly it's fruits and vegetables, meat, eggs, pulses and beans, milk or curd, that type of thing, not aerated drinks or sugared beverages. For children, we have quite an extensive list of information on what they ate yesterday and last night. The thing is, for children, one of the things we found in NFHS 1 was children have undernutrition problems from very young ages. And at that time, the ICDS program for preschool children focused on children aged 3 to 6 years. And the survey findings that it's much younger than that. You have to catch the kids much younger than that, because once they're undernourished at a very early age, it's very difficult to catch up later on. So based on those findings, the program changed to providing nutritional supplementary food and nutritional programs to all preschool children of all ages. But a lot of the problems at the very young age have nothing to do, they're still being breastfed, they're not eating a lot of other things. It's a problem with the feeding practices. Breastfeeding is not being initiated fast enough. It should be initiated within 1 hour of birth, and it's not often initiated for 1 or 2 or 3 days. Prelacteal feeds are given, not according to recommendations. The percentage of children who get exclusive breastfeeding is, for the first 6 months, is less than half. Those who get timely complementary feeding at around age 6 months, again, is less than half. And those who follow all infant and young child feeding practices at age 6 to 23 months, it's only 21%. So it's not so much these other things that they're eating, but that the standard recommended feeding practices at a very young age are not being followed by most parents. Well, there's been some improvement in stunting. There's been some improvement in underweight for children. It's only wasting that has gone up. So I wouldn't say that the situation is getting worse. It's just kind of stagnating. It's really not going anywhere. Yeah, anemia has gone up from 74 to 79%. I don't know. I mean, there are so many things affecting anemia, and like you say, there are things that affect. It's not just what you eat, but the bioavailability of what you consume, and some other things like drinking tea, for example, can interfere with the bioavailability of some of the important nutrients. So we can look into that more specifically. We have a lot of the feeding information.